Welcome, everyone. My name is Erica Ferriston. She, her. I am Director of Healthcare for All Los Angeles, along with Maureen Cruz. Maureen, give us a wave. Healthcare for All Los Angeles is a local chapter of Healthcare for All California, which is a statewide nonprofit, nonpartisan organization. Our mission is to achieve a universal healthcare system through single-payer public financing with the goal that all California residents have comprehensive, high-quality healthcare. And thanks to the California nurses, we have a bill. We have a single-payer Medicare for All California bill, Assembly Bill 1400, the Guaranteed Healthcare for All Act, also known as CalCare. And so that is what we will be talking about tonight. The format for tonight is we have a wonderful panel of speakers. We will listen to our speakers, and then we'll have question and answer toward the end. So for those of you on Facebook, drop your questions in the Facebook chat. And Paul Newman, Paul, you want to raise your hand? And Paul Newman, he will ask your questions. And for those of you on Zoom, drop your questions in the chat to me, and I will ask your questions for you. So if everyone but our speakers who are on Zoom could go ahead and mute themselves, that would be great. And before I turn it over to Maureen, and before we begin, we're going to have a land acknowledgement. This land acknowledgement is borrowed from White People for Black Lives. They've given me their permission to use this land acknowledgement. So, Healthcare for All Los Angeles acknowledges the Tongva peoples as the traditional caretakers of the land we currently reside on. That is the Los Angeles Basin, relations past, present, and emerging. And then if you are outside the greater Los Angeles area, you can find out whose land you are on at native-land.ca. And with that, I'm going to turn it over to Maureen Cruz.
Hello, everyone. Thank you so much for joining us. I'm very excited about this panel because each and every one of these people are just amazing professionals and wonderful human beings who have really made the effort to serve patients in their greatest times of need. So such a pleasure. We are all very well aware of the injustices and the cruelties that the insurance system imposes on patients, our families, and our communities. But trauma is also visited upon healthcare providers. We see this now in record rates of depression and heightened stress among those entrusted with caring for our needs. Healthcare professionals who have dedicated their lives to helping people at our most vulnerable are being obstructed from giving the care that they know patients deserve and need. The U.S. insurance business model profits by hijacking professional autonomy and discounting professional judgment, by controlling access and treatment, by delaying and denying us necessary care. So it is truly an honor to introduce 6 of these healthcare professionals to share their experiences with us. Each is from a different discipline to give us a broad perspective, demonstrating that the impacts on patients and caregivers is systemic across all healthcare professions. I'm going to read bios of all 6 kind of in a row, and then I will ask 3 questions, and each question I'm asking each of the 6 panelists to answer within a 3-minute period. And anyway, I'd like to start out by introducing Culver City Vice Mayor Daniel Lee. Daniel, can you wave to us? Hi, there's Vice Mayor Daniel Lee. He's a doctor of social work and the first African-American member of the Culver City Council in its over 100-year history. A veteran of the U.S. Air Force and California Air National Guard, he currently works as project manager at the James Lawson Institute. Daniel has a master's degree in social welfare from UCLA and a doctorate in social work from USC. Dr. Lee serves on the board of directors for Move to Amend, the Backbone Campaign, Mockingbird Incubator, and the Clean Power Alliance. Daniel's work is centered around the issues of ACEs, which is adverse childhood experiences and social determinants of, social determinants. Daniel is committed to finding ways to address poverty as an adverse childhood experience. Another of our panelists is Carol Fodera. She is an occupational therapist working with young children with developmental delays and medical diagnoses. She's currently a member of an interdisciplinary feeding team at a nonprofit clinic and previously worked in acute, rehab, and outpatient departments in hospitals. Carol is a valued member of Healthcare for All Los Angeles leadership team. She's an ardent supporter of single-payer reform and a dependable advocate who shows up relentlessly for the cause and does so much behind-the-scenes work to advance the single-payer movement. California native, Dr. Sara Deen. She earned a bachelor's degree in molecular and cell biology from UC Berkeley and a dental degree from UC San Francisco. Dr. Deen taught at University of California, San Francisco and Case Western Schools of Dentistry while raising 2 children with her physician husband, Omer Deen. Sara Deen completed a year of advanced education in general dentistry at UCLA. She taught dental residents and resumed clinical practice in Torrance. As the Muslim American community tragically experienced rising Islamophobia, Dr. Deen began organizing at local mosques to address the American Muslim identity formation, interfaith collaboration, and civic engagement. This led to board appointments at the Bayan Islamic Graduate School and the South Coast Interfaith Council. Dr. Deen took a hiatus from dentistry to focus on interfaith collaboration and pursuing social justice work. So Sara Deen serves as a delegate from the 66th Assembly District to the California Democratic Party and is a valued public speaker and outreach coordinator and leadership activist with Healthcare for All Los Angeles. Diana Guth is a registered respiratory therapist since 1971 and the owner of Home Respiratory Care located in West Los Angeles. For the past 26 years, Diana's company has specialized in treating people who suffer from sleep disorders and respiratory insufficiency. In addition, she is the respiratory therapist on the UCLA ALS Clinic Medical Team. Diana is active in numerous professional organizations that include but are not limited to the American Association for Home Care and the American Association for Respiratory Care. An accomplished public speaker, Diana is on the board of directors of Breathe Southern California, and Diana has in past years spoken to Healthcare for All LA as well, talking to us about the issues for her profession in this system. Hailing from Indiana, Gina Harris received her Bachelor's of Science in Nursing from Western Governors University. Gina is a nursetivist. She describes herself as a registered nurse and activist, a nursetivist. And she has worked as an RN in multiple clinical settings, including med-surg, cardiac rehab, acute dialysis, and transplant. Currently, she's an inpatient clinical case manager, facilitating the coordination of patient services across the continuum of healthcare needs. This role has allowed Gina to see that our healthcare system is fundamentally flawed and why small reforms just won't do. So Ms. Harris represents the 54th Assembly District as a member of the LA County and State Democratic Central Committee and has been a DNC delegate for Bernie Sanders in 2016 and 2020. Gina is the very knowledgeable co-host of a weekly Sunday 5 to 7 p.m. office hours with our own Dr. Ron Birnbaum. And on this interactive Facebook webinar live, Gina explains and answers questions about AB 1400 CalCare. So anyone who has questions about CalCare, tune in on Facebook, Sundays 5 to 7, and you will see Gina. As a frequent spokesperson for AB 1400 and a tireless activist, Gina also serves as a valued member of the Healthcare for All Los Angeles leadership team. Another native Californian from a Vietnamese immigrant family, Dr. Richard Huynh is a board-certified and practicing pulmonary and critical care physician at private Torrance Community Hospital. With a Master's of Science in Biochemistry and Molecular Biology, Rich received his medical degree at New York Medical College and completed his residency at Los Angeles County Harbor UCLA Medical Center prior to starting his pulmonary and critical care fellowship at UCLA. Despite the demands of new fatherhood, Dr. Huynh has become very active as a voice for his patients and community in calling for single-payer healthcare justice reform. An elected California Assembly District 66 delegate, Dr. Huynh is also a frequent spokesperson on the HCLA leadership team and active with Physicians for National Health Program, Los Angeles. So that's a lot to absorb. So the format will be, I'm going to ask 3 questions, and there will be 3 minutes maximum for each panelist to answer, and I'll kind of wave my hand at 30 seconds. So at the end, we will have question and answers both from the Facebook page and from the Zoom. We may go a little bit over 8:45 if there's a lot of robust discussion, and then we would go another 5 minutes. So I'm going to start. See, the very first question, and I'm going to start with Gina. Describe the first time that you became concerned about systemic obstacles diminishing your ability to serve your patients.
That goes back. I think that goes back to before I even became a nurse, I was an EMT at that time. And I noticed how patients were using the emergency room as their primary care doctor. And it wasn't just because of lack of knowledge, it was because of lack of access. They couldn't get into their doctor, or they just didn't know who their doctor was. And to me, that is a reflection of the industry and our profession. So I would say that had to have been 10 plus years ago.
Okay. Thank you. Diana Guth?
Well, I started my own business about 26 years ago. And that's when I really found out how things work or really didn't work and how expensive it was for me to be able to take care of the patients because of all the interference I had with the insurance company. And then I heard about Healthcare for All. I went and heard Sheila Kuehl speak. This is many years ago. And my eyes lit up. I said, yes, that's what we need. There is an answer. There's a solution. And so that's when I first learned about it. And I become dedicated to this very important cause.
Okay. Daniel Lee, Dr. Daniel Lee. Do you like the question? Is describe the first time that you became concerned about the systemic obstacles to giving your patients the care that they need.
Well, the first time I became concerned, they weren't my patients. I was actually in discussion with my brother and my sister-in-law, who are both doctors, and they complained about the lack of time that they have to actually spend with their patients and actually give them the type of care that they need and actually find out what was going on, frankly. The first time that I was personally concerned was when I was at UCLA completing my MSW. And I heard from a number of people in 2 different settings. In the first year, I was in the Santa Monica Malibu School District giving therapy. And then in the second year, I was at Community Coalition in South LA doing a similar thing in addition to community organizing and some other things. But the long and the short of it is, once you had spoken to people before, you heard that these kids who are mostly receiving some type of therapy or mental health support through interns, through MSWs, MFTs, some type of intern mostly, because that, augmented an organization's budget, they'd be making progress and then they drop off because their therapist graduated or went to the next year, and they just be completely cut off because they could not afford it themselves. And or this will go into a similar question. They could technically have it under their current insurance, but we can talk about how that's not actually the reality for a lot of people when it comes to mental health.
Thank you. Carol Fodera.
Okay. Well, I've worked in two major roles. First of all, I worked at Children's Hospital Los Angeles for many years. And I was concerned when a mom who had Medi-Cal for her son said that there was some time gaps in terms of her eligibility, and she had to re-register, and it was all very confusing to her. And so sometimes we didn't know if she would be eligible for the therapy. So the Medi-Cal system seemed very confusing. And also I remember that even though I had filled out a form and written a justification for why I wanted therapy for children, and then the doctor in the hospital who knew the child signed off on that, I'd still have to talk to the doctor from Medi-Cal to once again make a case for a child having therapy. And Medi-Cal really doesn't, I mean, I don't know what they provide now because it's been years, but whatever, 20 years ago, they didn't provide much. And not only did they not, you have to ask for frequency and duration. And the duration on Medi-Cal is always low. And so you're resubmitting forms, waiting for the doctor to sign, and all this paperwork shuffling. So now at the clinic I work with, we tried several years ago to get contracts with insurance companies, and they gave us the runaround constantly. One time they said, after we had submitted several times, they said, "Oh, you used the wrong font." So that's the kind of games that they play. And I have to say the contract we do have is with Kaiser. And, Kaiser's been pretty good. We have to every 6 months do quite an extensive report, but they do give us authorizations. And that's for children with medical feeding problems and children who have autism and other developmental delays.
Thank you, Carol Fodera. Dr. Sara Deen.
Thank you for the question, Maureen. And really, because no one's ever asked me that before. And what's implied in your question, listening to everybody's answers, where the answers have varied from the first time I realized that there was obstructions to my providing care was either before I was in my occupation or on day one, which then begs the question that our work is being obstructed every single day, and we normalize it and we accept it. It's like getting sucker punched every single day and then just taking it, right? So to answer your question, it was, again, no one's asked me that question before, and the truth is, on day one, my very first job as a dentist, it was explained to me that I had to produce $6,000 production units, which I understand, it's a business, that's okay. And I was given 2 dental chairs to use, as was every other dentist in the office. One chair was called, and I'm not making up the name, this is what it's called. This was in the state of California, and this is pretty typical. One chair was my HMO chair, and one was my private cash or private insurance chair. And what I was told was, however you want to do it, whatever mix you want to do. So if you want to see only HMO patients, or you want to see only cash, or you want to mix it up, that's fine, but you have to produce $6,000 a day. And the thing with the HMO patients is, the way a dental office gets paid is you get paid a lump sum per HMO patient for a period of time. So let's say if I'm carrying, so for like any given patient, I get a lump sum of money for the year, regardless if that patient comes in 1,000 times or that patient comes in only once. So the way you make money in that HMO model is you want to carry a lot of HMO patients, right? So that you get paid a lot because you're getting paid per patient per year. There's nothing here about quality or standards of care, right? So my choice was either I see a high volume of patients, so I carry a heavy load and I only spend, and Gina's reminding me in the chat, that is a capitated model and that is extremely harmful to the health of patients. And it's important for us to become familiar with that word. So it's a capitation scheme. So either I saw a high volume of patients to make my 6,000 production, or I could shift over into more private cash patients. I had just graduated from UCSF. I was really passionate about providing a high level of care, and I was unable ethically to cut the corners needed to see that high volume. So over the course of 1 year, what happened? I gradually whittled away. I was not seeing patients in my HMO chair, and I was primarily seeing cash patients and PPO patients. That means my HMO patients, who are human beings like you and I, who deserve every level of excellence, who deserve equal access to the best dentists, the best doctors, were not getting to benefit from my care in this situation. I mean, I've heard it said, we have a caste system, we have a tier system, however you want to say it. But it was on day one, and that to me was an obstruction. How can I practice good dentistry when you're giving me 5 to 10 minutes with a patient? I can't do a crown in 5 minutes. Thank you, Maureen.
Thank you, Sarah, so much. And Dr. Richard Huynh, pulmonary specialist.
Thank you. And everyone's stories, you know, a lot of it is very similar in that very early on, you realize what a terrible system we have. My first realization that the system was broken was even before I went to medical school. I remember I had kind of snuck into the hospital to watch my brother work. He was a resident at the time at USC. And at USC, there's an interesting system where there's the county hospital. And this is before this nice, beautiful hospital that had recently been built was there. It was what we called Old Mother County at the time. And next door to Old Mother County was Keck USC, which is a private hospital. And so he gave me a tour of the hospitals. And I said, well, why is there 2 hospitals? Why do we have a county hospital? And then why do we have a private hospital? And he explained to me what the difference was. And immediately I said, well, why are we giving different care to different people just solely based on their insurance status? Shouldn't we give them equal care and equal treatment? So that was the first time. So it was very early on in my career. But I remember, since I have a little bit of time, I remember the time where I said enough's enough and we need to do something about this. And I apologize because I always tell stories. I remember it was during my first rotation as an intern. So I was fresh out of medical school. And I had a patient who unfortunately had contracted hepatitis at a very young age and had her liver become cirrhotic. And she was one of my first patients. And her cirrhosis had her liver had failed, and she was no longer able to breathe on herself. She was bleeding everywhere because your liver creates factors to keep your blood coagulated. She was no longer mentating. She was no longer awake. And I remembered her family came to her bedside, and it was 4 little ones and her husband, and they prayed for her. And I told my attending physician, who's my supervisor, and my resident, I said, we have to do something for her. We have to fix her. And they said, Rich, the only way that she can be fixed now is with a liver transplant. And I said, well, let's do that. Let's get her a liver transplant. And they said, well, she doesn't have insurance. And I remembered that we had to sit down with the family, with the husband, and tell this poor man that he was going to have to raise his children alone. And we tried of all of our heart to refer her out and call up, the closest transplant centers. But the reality is that until she had insurance, there was no way that she would be able to pay the rejection medications. There was no way that she would pay the liver transplant. There's no way that any of that can happen. And I remember that day, I told myself that, I need to do something about this, because otherwise, if I keep on encountering these types of stories, I was not going to make it as a doctor.
Thank you so much, Rich. Thank you for sharing that. It's heartbreaking. Everyone's story is heartbreaking. So given that everybody has experienced this, the tragedy and the cruelty of our system, the next question is, what motivates you to advocate for single payer? And I'm going to ask Carol to go first.
Well, of course, the children and the parents that I work with now definitely motivate me. But, I think about the adult patients that I worked with during my internships and my first year of work. I worked at Torrance Memorial Hospital. It was a hospital then. It wasn't called a medical center yet. And I worked on the burn unit, and I remember working with people who had 50 to 75% body mass burns. And I worked with patients with brain tumors who, after the brain tumors were removed, they still had major cognitive problems, problems with they couldn't do their own self-care. Even if they could physically do it, I remember one man who he just kept washing the same arm. He didn't have the cognitive skills to bathe properly. And I think, like Rich is saying, you remember those first patients. you remember them really, really carefully. So I think back to them, and I think it's not fair that people have that kind of physical and mental stress in their lives, and they have to add on financial worries. That's just immoral. And I think about our artists and musicians who don't get paid much at all. And we need them. If we're going to have a well-rounded society, we need them. And I really worry about them. I have a child who's 24. She graduated with a degree in music. She plays the oboe, a very specialized classical instrument. Unless she gets into a city symphony, I don't know how she's going to have healthcare. So I'm very concerned about our musicians and our artists, and how not having healthcare impacts our society at large. Thank you.
Thank you, Carol. These are all such heartrending stories. Sara, what motivates you to advocate for single payer healthcare reform?
This is a really heavy question because the stories in our communities and our patient stories are really heartbreaking. The place where I see hope, though, is in the way providers care for their patients. That's where I find hope, that despite living in a world and a time where everything is monetized and value is only placed on production dollars, that when you get down to have conversations with healthcare providers, whether they're your nurses, your occupational therapists, your physicians, that oath they take when they're finishing their training and as they start to serve, that oath and their commitment to it and how passionate. I know some physicians who have thriving practices, who run surgical centers, and perhaps there are, you know, they're doing financially well. And still I see when they post stories or they share their patient stories, that feeling they get when somebody goes from feeling unhealthy, unwell, to feeling well again, that humanity is still there in our providers. I feel like we have all the ingredients in our society, in our country, in our state to do something really beautiful. It's right there in front of us, in our healthcare providers and their dedication and their practice of service to humanity and their fellow human beings. We just need to imagine what that world would look like and find a way to carry us forward and really remove that obstructing noise of the insurance companies. But I don't know if that was a helpful answer.
Yes, everything everyone has said is a helpful answer. Dr. Daniel Lee, what motivates you to advocate for single payer reform?
So this might be coming from an odd angle, but my real passion is around education as a tool for social uplift to some degree. But if you look at any of the studies in more developed nations, you know, it does good for a while, but once a country becomes so developed, it sort of plateaus. And for me, you know, prior to going into doctoral study, I just assumed, like I had spoken to a lot of different teachers, I had spoken to administrators, it's because education policy is focused on everything except the student. And it's really not focused on what they're experiencing. And if you know LAUSD or Los Angeles County, a lot of students are hungry, malnutrition, homeless, you know, they might be sleeping in a car. And a lot of people in certain neighborhoods may have seen either violence perpetrated in their neighborhood, on their mother, their father, someone in their family. And we talk about trauma a lot, but we don't talk about addressing that trauma as much as a policy solution. So a lot of my motivation is around particularly Black and brown immigrant communities, low-income communities, where there is a lot of trauma, but it's not treated, it's not addressed ever. There's this acknowledgement of it, but there's no effort to put infrastructure in place to help people heal. And that basically manifests itself when these kids grow up. Or, you know, if they have the opportunity to grow up, because, you know, their behavior changes. They don't have the same decision-making capacity. They don't think about the long term. There are a lot of things that come up that can make their life either shorter or their medical life much more disease riddled as they grow older. And, you know, my motivation around part of my number one motivation, I have a lot of others. My number one motivation is, you know, trying to give these kids more of a chance. And I feel like, you know, you can change from whatever to Common Core, you can get a new principal, you can change out the teachers. It doesn't really matter if, you know, a kid's sleeping in a car and they just saw their mom get beat up 5 out of 7 days, you know, for the last 6 months. Like, you need to actually address the things that are really causing the problems, the things that they think about. The reason why they can't stay awake at school might be because they haven't gotten to sleep, you know, for weeks. And these are the things that I think a single payer system can help address from the mental health perspective. There are a lot of other things that go into it around housing and other social service support, but I think mental health is a big thing that the US as a society, the world as a society largely really hasn't prioritized, and it's one of the things that's holding a lot of us back. And a single payer system, in my mind, includes universal mental health care coverage too.
Yes, it does. Thank you. Dr. Huynh, what motivates you to advocate for single payer reform?
I think there's 3 things. I think the first, obviously, are the patients. You know, I've always been taught you treat every patient like they're your loved one to the best of your abilities. And, you know, unfortunately, because of the system that we're in, this tiered caste system, we're not allowed to do so, or it's very difficult to do so. And so I think that's the number one reason. Number two is a little bit selfish. I oftentimes, you know, because I tend to share a lot of stories and a lot of them are heartbreaking, I oftentimes get asked, you know, do you go to therapy, or do you get, you know, treatment for PTSD? And, you know, and honestly, this is my treatment. This is my therapy. This is how I feel like I can make the world better, and I can push for something that will help, you know. And so that's somewhat selfishly, it's my therapy. And then three, I think you saw a cameo this earlier in this meeting. It's Allie. You know, I want this world to be a better place for her, and I want her to be in a world where the U.S. is, you know, along with all the other civilized nations in the world, and have a single payer system. So those would be my reasons.
Thank you. Diana Guth, what motivates you to advocate for single payer universal health care reform? Oh, you're muted, Diana.
I want to talk about how awful the insurance companies are with, I get it on all sides.
Yeah.
First of all, I'm a healthcare provider, I'm an employer, and I'm a consumer. So as a healthcare provider, it's been a nightmare. It's so obvious to me that the insurance company uses every trick they possibly can to pay us as little as we can, delay payment, deny payment, really limit people's choices. People should be able to go to whoever they want. I'm a small provider. I give very personalized a treatment to my patients, but most people can't come to me because I'm not in network. And to get in network costs a lot of money. I have to hire marketing people, and they have to find all these different people to get contracts with various HMOs, etc. And then those people move around. It's not something I can do. And so they're denied really treatment from me and my staff. And then as an employer, I care deeply about my employees. I want them to have good health insurance. And every single year, I have seen the insurance premiums go up double digit. Every single year. Can you name any other product where that is even allowed, where people would put up with that? And as it is now, I donate, I give each employee $600 a month towards their health care, but that doesn't always cover everything, because some of them are covering their families. And really, I have one employee who has an autistic son, and her husband, who was a chef, lost his job during the pandemic. And I just can't, I have to help her even more. She's a wonderful employee. And then I'm a consumer. Well, you know what? I'm also a cancer survivor. About 10 years ago, I got lung cancer, of all things, for a respiratory therapist. And so unfortunately, I'm here. And I had a left lower lobectomy done robotically at City of Hope. I fortunately didn't need chemo. I didn't need radiation. And I had a high deductible healthcare plan with Aetna. Guess what happened? The following season, they said that because I was a high user, they didn't offer the same plans that they did the year before. And for the plan that I wanted, which was much less than my previous one, they doubled the premium. And so we had to go out looking for a different way to get health insurance for our employees. So that's just, that's just a little taste of what I see, how they waste our time. we need to get prior authorization for a patient. So we call Blue Cross. They don't hesitate to put us on hold for 45 minutes. Ask any healthcare provider that has a practice. They're wasting our time while they're paying somebody else while we're losing money. And we can't do other things. I mean, I have to buy extra lines. To be put on hold that line, that person has to have 2 phone lines so they can do other things and answer the other phone to take care of other people. So that's just a small example. And it was really amazing for a long time before we had more electronic a way of getting paid. It's amazing how often the claims that we mailed in got lost. All right, they got lost, at a much higher rate than any other bill that you pay. So that's just a small example. And also with my ALS patients, they come in and they come from all over and they have all different health insurance. And we try to treat them all the same way, but even that isn't possible. If they're getting home health, then the physical therapist isn't allowed to see them and charge for their service. It's just crazy. It shouldn't be this way. It just absolutely shouldn't be this way. Also, if I have an ALS patient who now needs a ventilator, I shouldn't have to ask for an authorization and wait 3 weeks. They can't breathe. They're losing their ability to breathe.
Thank you,
So
Diana.
that's just a small.
Yeah, Diana, I know we had you before, and I think it was an hour and a half, and you didn't repeat yourself once, and it was astounding. So thank you so much for your work and for sharing that with us. And Gina, what motivates you to advocate for single payer reform?
What doesn't motivate me, I think, is a better question.
Yeah.
But I'll be honest, I'm tired. I got into healthcare. It's all I know, honestly. At a very young age, I worked level 1 trauma starting at 17 years old. And, I've always seen the bottom of the healthcare system and the worst of the suffering. But because of that, I am tired. And now I realize a lot of that suffering is unnecessary. We are a very unhealthy society, and it is not just due to lack of health education. Our minds have been totally manipulated from everything from the food we eat to the air we breathe to the things we drink. And so I can't just sit there and hold fault to people and say, oh, you're just not unhealthy. And I'm like, you haven't been told anything else. We have food deserts and all this stuff. And while, I'm going off on a tangent slightly, but it all is tied to healthcare, because if you look at the food desert environmental racism, I typically used to drive to my office in Commerce from West LA to Commerce. And if you take Slauson straight down, you can get to Commerce. And once you pass the 110, you do not find a grocery store. You find a few 7-Elevens, lots and lots of liquor stores, but a good grocery store. There's no Trader Joe's, there's no Whole Foods, there's no, you'll find the fruit vendors, yes, but you will not find healthy things. And then on top of that, you have bad air quality, and then they don't have access to care. You have the Hubert Humphreys clinic that's been there for a very long time on Slauson, but other than that, and so these people are suffering, but these are the people that hold up our society. And so I do this for them. I do this too because I don't want Rich's daughter coming after me when I'm in my 40s and 50s, where the millennials and Gen Zs might be coming after the baby boomers. I don't want that either. I want to be able to say that I fought and I stood up and I made a change. And so, but lastly, it's because I've experienced every side of this healthcare system as a provider, as a patient, as someone with no insurance, someone on Medicaid, someone who's got the premium PPO insurance. I've experienced it all. And I can tell you the division is so real, and that is just not fair. We cannot criminalize poverty. Poverty is not a crime. I didn't choose to be born with the color of my skin. My parents were fantastic parents, but you know what? Not everybody has Bezos money, and we shouldn't be criminalized for that. And so that is the reason why I fight for single payer healthcare, because I know if we can be healthy, then we can thrive, not just survive. You know, we're surviving now. We all survive at some very level. If you can breathe, you can survive. But we should be able to thrive. Why? Because we're Americans. Or you're in America, you know, and we're supposed to be this great country that I think somebody said, I don't know, some guy said that America was great. But, you know, I think that is why I do this, is because I'm tired of survival. Survival is not something that we should be aiming towards. That should not be our goal. Our goal should be to thrive and maybe save the planet. I don't know.
Thank you, Gina. You are all such marvelous people. I'm so happy to be here with you on this Zoom. Last question is, how would a single payer healthcare system like AB1400 CalCare help you and your colleagues better care for your patients? And Dr. Huynh, I'm going to start with you.
It's a total game changer, you know, it's a total game changer. There was a meme that was going around that said insurance companies are not your doctors. And right now, you know, a lot of times when I want to put in a CT scan, when I want to order specific medications, it all has to get approved first. Surgeries need to be approved. Forgive me, but I don't think these insurance companies have ever seen my patients. Forgive me, but I don't think they're the ones who have gone through medical school or extra training or anything like that. But somehow they're able to like question what my judgment is, even though I was the one who sat in front of the patient, examined them, went over their, you know, scans with them, went over their test results with them. But somehow you're not going to approve of my study. Somehow you're going to have that power to delay their care while the patient could have cancer or some serious infection. That's what it is. It's a total game changer to have the power put back into those who actually want to put the patients first, rather than those who want to put profits first. That's what it comes down to. AB 1400 would just be a complete game changer.
Thank you. Thank you, Dr. Huynh. Sara Deen, how would single payer healthcare system like AB 1400 help you and your colleagues better serve your patients?
I think game changer is really going to be the word of the night. One of my preferred places to practice dentistry was at the university, because their financial interest is different. It didn't matter. I didn't have to produce a certain amount. It wouldn't matter if I, you know, was only doing one procedure versus 100 procedures with a patient. But if we had single payer healthcare, I would not have to have this conversation that I had to have so often. You know, dear patient, this is what you really need. This is what will take you out of pain. This what will allow you to eat comfortably, to speak comfortably, for you to feel good. Patients who, we don't think about these things. The patients that stop picking up their kids at school because they don't want to embarrass their kid because their teeth don't look good or they've fallen out. I had one patient once, her son had bought her a computer, but she didn't know how to use the computer. She wanted to take a computer class to get some computer literacy, but she was too embarrassed because she didn't have teeth. So, you know, with these patients of mine, having to tell them, this is what you need to get health, to be able to chew, to be able to smile, to be able to speak. This is what you need. This is the best treatment, but this is what you can afford. I and everyone else here would never have to have that conversation anymore. What I would give, not to say those words because they are vomit inducing. I hated saying those words.
Thank you. Gina, how would single payer healthcare help you and your colleagues better serve your patients?
Allow me to take a restful vacation. And the reason why I say that, you know, I'm being funny, but I'm also being real. Like when I go on vacation, and I just came out of management, honestly, because I just got burnt out, but it would take about 4 days of me just worried about what was going on. Would this patient get covered? Did this get done? Blah, 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 blah. And it was mainly the care coordination. That's what I do. I would be that one that Rich would come to and say, Gina, what's going on with this patient? You know, what's going on? Why can't we get this patient this CT? The patient needs this outpatient thing. And I would come back and be like, I'm fighting with the insurance. It's like, I've been on hold for 45 minutes. I'm trying to make it happen. And the also patient, like the work that I do as a patient advocate, I go above and beyond, but I can't do that for every single patient. So if Rich told me, Gina, this patient really needs to have this done outpatient, I'm okay sending him home, but I need to have this done. And if I couldn't get it done just because I would like Rich, and I'd be like, okay, you know what, for you, I'm going to do this. I'll be your fairy godmother. But I would take more time out of my day, which means I'm getting behind on my own work, just to make sure that one thing got done, which means I have to answer to my boss, which adds extra stress to me because he's going to wonder why I let other things fall through the cracks. But it was because I was on the phone for 45 minutes trying to get something done that was so simple. And like you said, I'm arguing with people who don't know these patients, who don't know. And I know this system, and I'm still telling them it meets criteria. I fought this today. It meets criteria. I pulled the guidelines. I pulled Medicare. I pulled the health plan. And this is all taking extra time out of my day. I'm sitting here, pouring soup down my mouth as I'm sitting here reading these guidelines, trying to find that one thing that this health plan is trying to say is wrong. And I'm like, it's not wrong. It's like, you're just interpreting it wrong. And I'm like, why is this up for interpretation? It's like, I have proof. It's a guideline. I have an order. I have a signature. What do you want? And so without all of that, I would have been able to take an actual official lunch, which is important. And then B, that patient wouldn't have got the care that they wanted or needed, not just wanted, but needed. Maybe facilitated a better timely discharge, which actually is more cost effective because now that patient stayed an extra night, $4,000 because that one little thing with the insurance company couldn't go through. So now that insurance company's actually got to pay out more money. So you want to talk about cost effectiveness. Doesn't that sound rather wasteful to keep that patient there? And so that is the reason why I fight for single payers, because it's A, myself, B, this current system is wasteful. And then C, like I said, being in clinical care, case management, care coordination, one thing that we would love is to be able to not have to fight with these insurance companies because they're making the fight a lot harder. So now I'm getting vindictive. And so passing AB 1400 will be just kind of like the middle finger to them, and, me getting my money back. So, that's how I feel. That's why I do this. And that's why I do CalCare office hours and everything, because I want as many people as possible to know how grimy these insurance companies are, because I just came from a under one. And also to get people to understand that, even healthcare providers don't understand totally what's going on. And I want everyone to know that, we can do this and it is not some revolutionary thing. We are so behind the time on that.
Thank you so much, Gina. Fantastic. Diana Guth, how would a single payer healthcare system like AB 1400 help you and your colleagues better care for your patients?
Well, just think, we get a prescription sent over from a doctor and we call the patient and we make an appointment for them to come in and we get to see them. The first question isn't, what's your insurance? We've got to get authorization. None of that's there. The patient gets to just come in and get treated. And let's get rid of all this other stuff.
Absolutely.
I mean, isn't that in a nutshell? Would
Absolutely.
all of you like to be able to do that?
Absolutely. Total freedom. Yes.
Yes.
To actually be cared for and
Yes.
to serve your patients.
Right.
Those so simply put.
Yes.
Daniel Lee, how would a single payer healthcare system like AB 1400 help you and your colleagues better care for your patients, your clients, patients?
Well, for me, like very generally, just to go back to mental health, it would make it not a financial liability for families to seek out mental health. And the same thing goes for physical health as well. Even though the Affordable Care Act expanded health coverage and covered more people, a lot of people and a lot of families in particular still pay a lot of money. And the fact that, insurance companies were still allowed to be insurance companies meant that the promises that we heard about premiums being only this much or only that much didn't really bear out for a lot of individuals of a certain age and families in particular. But taking the cost question out of the equation for people when they consider having care, because, as I said this weekend at the rally, there are a number of things that, I did as an insured person, but not as an elected official, that ended up, costing me thousands and thousands of dollars. And as an elected official, so far it's been a couple $100s for about the same amount of care. And one of the reasons that we have such grotesque income inequality in this country is that a lot of people have medical debt. A lot of people have medical debt. It's not something that you can avoid at a certain point. You can delay, you can siphon your pills, but at some point you have to see that doctor, you have to get that procedure, you have to get that prescription, and it costs a lot of money, and it keeps you from being able to save for a house, save for your children's tuition, save for yourself, just to take a vacation, like Gina said. And I think if we eliminate that, we increase the potential for people to not just survive, but to thrive as humans.
Thank you so much for that. And Carol Fodera, how would single payer healthcare system AB1400 CalCare help you and your colleagues better care for your patients?
So CalCare would let us have continuity of care. That's very important for our patients, our clients. Like I said, I see children through Kaiser, but I also see a lot of children through the regional centers. And with the regional centers, for a lot of the children, when they turn 3, they don't qualify to be regional center clients anymore. So if they don't have Kaiser, then we have to stop seeing them. And that's really rough when you've built a close relationship and the family trusts you and the child trusts you. It's really a shame that we don't have that continuity of care. Other things are, teams, medical teams, therapy teams, school teams are really important. And I think that if we had more teams for outpatients, that could be really helpful. And so I work on a team with dietitians, psychologists, MFTs, and we really provide wonderful care. So I'm hoping that with CalCare, we could have more of these teams available. And, insurance doesn't cover dietitians very often. And unless you have diabetes, and dietitians, I believe, are really undervalued. So I want to give a shout out to dietitians, because my work is so much stronger when I can consult with a dietitian. The other thing that insurance doesn't cover is, especially for children with autism, is floor time. I don't want to go into what floor time, I would love to, but we don't have the time to go into that. But let me just say, it's a wonderful form of therapy. It's a very humanistic, developmental, relationship-based form of therapy, and insurance companies don't cover it. And so I would love to advocate to the CalCare board to cover that. And lastly, I know Diana mentioned one of her employees who has a child with autism. Well, when you have a child with autism, and let's say they have speech therapy twice a week, they have OT once a week, that you're looking at 3 copays for therapies every week. And that doesn't even include the copays for the doctor's visits. So, and I know families where they have 2 children with autism. So, paying for copays has got to stop. So we need CalCare, we need it now, we needed it a long time ago.
Thank you so much, Carol. Thank you, everyone. You have provided such a window into how providers who care so much for their patients are prevented and impeded from actually doing what you're educated to do and what you want to do and what needs to be done. So Now we'll go to the portion for some questions. Any questions from Facebook or from the Zoom?
Yes, Chris Shimizu has a question for Gina and Richard. Does UCLA support single payer?
I can't speak on behalf of the organization, especially since I'm new. But, you know, I know that there are single payer advocates who work within the organization. Some of us, we all know. And so I know that I don't know on behalf of the organization, no clue. And I can't see them coming out really bold, but I do know that there is, you know, tons of support within it. CNA is the nurses union there. So CNA has presence at UCLA as well. And thank you, Maureen, for adding that in there. But I would not expect to see like major university systems or like these big organizations just coming out and saying we boldly support this. If they did, I would be like, oh yeah, we're passing this for sure. But I'm not going to expect it.
Okay, here's another question from Thomas Milcarek.
Hold on one second, Dr. Rich. Did you have anything on that?
Oh, no, I was just going to say I'm not a part of UCLA anymore, so I don't know.
Okay.
Sorry about that. Okay, Thomas Milcarek wanted to know if holistic medicine basically is covered under CalCare or would be covered under CalCare.
That would be Gina, our expert.
I was being quiet for a reason on that.
Oh,
yes. Holistic medicine. I would have to pull up the bill. I know it did talk, there's something about alternate therapy in there, but I can't quote it right now. I am sorry, my brain is just fried from the day. But Sara, are you looking it up? I see you looking.
What I would say is, I was trying to look for it really quickly. What the bill does articulate is that the CalCare will pay for culturally relevant treatments.
Thank you.
The way that's worded is to allow, and I think it's beneficial to keep it gray, so there's more space there for interpretation. But the bill does account for the way different groups of societies of people and social groups approach healthcare.
Yes, thank you so much. I knew it was something around that language, and I did see the binder come through, so that's why I was like, I know she's looking it up.
And it does say that specifically that alternative therapies that have some proven efficacy will be included. And also the boards that make these decisions, the advisory committees, will have people from a variety of disciplines who can introduce. It will be a fluid system once it's in place, and there will be constant evaluation and reevaluation as to what should be included, what is needed. It's not, because it's there to serve patients and be patient-centered and patient-friendly. As things come up that would serve the needs of patients, I believe I know there's definitely space for those things to be included.
Okay, then we have another from Chris asking, what kind of support is the bill getting from universities?
I don't have anything. I don't have anything on that, honestly. I have not seen a university. Like I said, going back to what I was saying previously, that would be a very bold step to see a university, especially big university systems, our UCLAs, our USCs, come out. Honestly, I would say that if I see something come out, it will be from a small community hospital, a rural community hospital, because they have almost the most to gain right now.
Well, we have seen that universities such as UCLA have supported things like single payer through their research, right? There have been numerous studies coming out of universities that have shown support towards single payer. I think when it comes to things like, physical bills and legislature, I think universities tend to steer clear of that because it's not a part of their mission.
Yes, I would add that's a good point, Dr. Huynh, because UCLA Health Policy Research Group, they do come up with a lot of these studies, and they were the research group that came up with the fact that of healthcare dollars in the state of California, 71% of every healthcare dollar spent is taxpayer funded. And that did come out of the School of Public Health at UCLA. So that's an excellent place to look for the latest research. They do really good work.
And I just wanted to add the CHBURP, board that does the health reviews is actually UC Berkeley. So the universities are are involved. But like I said, when it comes to endorsing, like Rich said, legislation, I wouldn't expect that. But they have their sly ways of sprinkling their their things on it. I think Diana.
Yeah, well, I think that I don't know, like you said, politically, I don't know if they'll come out and support it, but I mean, they're a huge medical organization, and they're burdened just the way any other healthcare provider is. And I think they would very much be in favor of it. It would save them a great deal of money in terms of time of employees. Actually, they won't need as many employees. They could devote more time to just patient care. And they, they're burdened with things like Medicare. If somebody with let's say COPD is in the hospital and they get readmitted after they're discharged within 30 days, the hospitals get a penalty if the patient gets readmitted. So there's all kind of things going on that would tell me that it would be very much cost effective for them to support this.
I have one more question. It's from Dutch Newman of Santa Monica. And the question is it's understood that AB 1400 is a policy bill. Gina, could you go into that and explain what a policy bill is?
My understanding of policy bill is really on the surface and high level. But, basically this is just saying a policy. I like to use, the thing, it's like the framework of a house. Like we have the architectural sketches of this house that we want to build, and we have maybe the rules that we need to build it within, and the policy is saying, okay, well, here's your structure, here structure, and here's a foundation, and I want to build this, right? And so now we're taking it to this body, which is now the assembly, and they're basically like our builders, and we're asking them, hey, can you approve our plans to build? It's not concrete. This is just a plan. I want you to approve my plan to build. This is a policy we want to build. It's not, it's not something that's going to be done overnight, but we want to build it. Can you approve our plan to just start the building process and to, make it more official? And so that's how I look at it, kind of in a high level overview of a policy bill. It's getting AB 1400, of course, is getting a lot of different rap in the, on the political sphere about it being policy and not policy. And then, the budget, all this stuff. But really all AB 1400 is our framework. It's a frame. It's a very strong frame, though. It is not built on sand. It is a really great frame. And really that's a policy. The policy is just saying, okay, we want to build this program. And because this program is going to be a game changer, as Rich said, now they're throwing in a lot of this slewy, political jargon that is making it confusing. But really, the policy is just like any other policy. You have something to work within. That's basically all policies are. But yeah, that's what happens when you have game changers.
And I would just add one more thing to what Gina just said. So if you think of the bill as the blueprints of the framing of the structure, I think the other thing that needs to be said is this is not just any blueprint. Like this plan really took in, like you would do a geological survey, you would do a seismic survey, you would do a climate survey, you would do a social survey. If I build this house, how will it affect the neighbors? Is my kid going to be left without a warm bed, right? Like this vision that's laid out in AB 1400 really mindfully takes in all of us into consideration. Those of us who have a lot, those of us that have a little, those of us that speak English well, those of us that don't speak a word of English, those of us that have a lot of privilege or identify as, you know, male, female, some of us that are all of the different possibilities. They've taken time to consider everyone's needs, and that plan is built accord has been articulated in that fashion. And then the funding is just going to be, well, now how do we collect the materials, right? And when you're bringing up, well, how are we going to pay for it? It's like somebody folding their hand and saying, I ain't just going to build. I ain't got the materials, you know? Well, what we're saying is, well, let's talk about the frame. You know, we know we need to put a roof over, you know, like it has to be built. We can figure out how we're going to get the materials, right?
I'd like to just jump into when it comes to the financing, we can afford it. It's just a matter of what method do we want to pay for it. Like, we're going to put it on a credit card, we're going to do layaway, pay it up front, pay cash. I mean, so we can afford it. So just wanted to add that. We do have a question from the Zoom here from Jackie. Do we have an idea of the percentage of health workers that support Medicare for all? And Jackie, do you mean the national or AB1400 or both? But if you guys have an answer for either or all, please share.
The last statistics that I saw, which was a while ago, hopefully they're better now even, was about 90% of nurses in the state of California. The majority of physicians, I think last I looked, it was like 66% of physicians. I don't know if other workers have been polled. It would seem to me, for instance, a lot of the workers that are, for instance, working in nursing homes and senior living facilities have every reason to want this, both personally, since they are low-wage workers, and professionally as well, that they would be paid, you know, a better wage. And as workers, they wouldn't have to pay in so much for their care.
Right. And I just wanted to, because now I actually had a good conversation with one of my new colleagues who's a social worker. So I wanted to maybe see, like, from Daniel's point of view, like in his realm, how AB, like the conversation has been.
Well, I think generally for most of the folks I know who are social workers, and a lot of them work at DMH or DCFS, but a lot of folks work at UCLA or County USC as medical social workers, or Harbor UCLA. For them, it's the same situation, especially if there are people who have some type of long-term care requirement or are in the hospital, for instance, for a long period of time. It would allow them to be there more, not just for a patient themselves, but for the patient and their family. Because I think with a lot of medical social work, there's a lot of trauma and there's a lot of grieving, and the grieving process is protracted. And that's something that has historically gone unaddressed, or it's gone addressed by doctors and nurses who do have good bedside manner, and unaddressed by doctors and nurses who don't, who are just like, you know, oh, your mom's dead, and they move on. I think, you know, from a social work and just a mental health perspective very generally, because, you know, MFTs, psychologists and psychiatrists are, you know, affected as well. It would give this opportunity to provide more comprehensive care, not just for the person outside of everyone who they might affect, but for those people who are affected. Because, I mean, we've all lost a loved one at some point. Usually most people have by the time they turn 20 or 30. And for us who are older, it's quite a few. But, you know, there are quite a few deaths that hit very hard. And if you don't have that type of support, other things could manifest, you know. I mean, depression is to some degree something that runs in families, but it can also be triggered. Anxiety the same way. And death is something that can trigger it. Trauma associated with death. Often, you know, people within your family asking you to basically suck it up and move on, and being unwilling to talk about it so you don't process it at all. All of that stuff weighs heavily on you. So having a greater opportunity to serve not only that person as they might transition, or that person who is not going to transition, but they are going to have multiple procedures and then physical therapy, and then they're going to have to come back again, and they're going to get frustrated about being at the hospital all the time. But if they had some type of mental health support or more mental health support, then that entire process could be made easier, both for the person who's receiving physical health treatment and for the people around them.
Thank you so much. Are there any other questions in the chats? I would like to give each of you just a moment to just make one quick comment if you have anything else to say before we say goodbye to one another. Sara?
I was just responding to Erica. I just wanted to echo what Erica was alluding to. Maureen, this is really difficult work, and usually the conversation around this topic can be really negative and antagonistic and leaves us all feeling grumpy and more unhappy. But you brought such thoughtful questions that instead of just pointing us towards all the things that are wrong, but you also gave us opportunities to share all that is right and all that could be. So I really appreciate your questions and your facilitation today. It was a really rough weekend we had a lot going on this weekend. So this was a wonderful, wonderful way to spend a Monday evening. Thank you.
Thank you. It wasn't hard because you are all the positive reasons why we're moving forward, everybody on this call. So Gina, do you have one last comment to make? So thank you, Sarah.
Support AB 1400. But like Sara said, like Rich said, this is what gives me the energy I need. Every day we're tired, we're exhausted, we're worn down. But we do continue to feed off everyone's energy. I do think that is something that we need to continue. So continue to spread love and light because it's so needed in the world tonight and moving forward.
Diana, any last comments?
I think there's a lot of hope. I remember a few years ago, if you use the term single payer, people go, huh? They didn't know what that meant. And I think just about everybody knows what it is, and they're really starting to support it. We just need to spread the word and do a lot of explaining. I don't think they feel as threatened as they did at one time. They personally, it's too many people that are having too many problems getting to good health care. And so I think that sells it.
And Daniel Lee, any last comment?
Just very appreciative of the work. I think all of us are in the place where we really want California to lead. Unfortunately, I'm a little bit cynical. To some degree, California will be leading us forward into the 20th century when everyone else had universal healthcare. I want to keep reminding people of that because I'm like, this isn't controversial. This isn't revolutionary. This is something that we should have already had. And I know a lot of people on this call are engaged in other struggles that are very important. And I think a way that we, can be more responsive and ready and healthy to engage in those struggles is, by having really quality healthcare for everyone. We need to save the world, and we need to be healthy to do that.
Yes. Thank you. Carol.
If you don't have your health, you can't work, you can't reach out to other people, you can't play, and health is just core, it's core. And so, and I think the younger generation really gets it because they're financially impacted more than a lot of us who are older. So I have faith that the younger people are gonna rally for this, but like Maureen says, we've been bamboozled, and we've got to tell people that we all deserve better and we need to fight for CalCare.
And Richard, Dr. Huynh.
I always say that, the central tenets of the United States is life, liberty, and the pursuit of happiness. Without your health, you can't have life. You don't have life. You don't have liberties. And you surely can't pursue happiness. And so that's why healthcare is so important. And that's why it is a right. We all should have healthcare, and we all deserve healthcare. And we deserve a system that is not broken, that is not a caste system, that is there for us. We deserve AB 1400. And AB 1400 is a game changer. It will take care of you from the day you were born to the day you die, from prenatal care to long-term care to the end. And so that's why it's so important. And I just want to say this, see, now you guys see why I say this is therapy for me. Seeing all of you guys are all such inspirations to me. To see all you speak from your different walks of life, from where you come from, and see what you do, it makes me just feel wonderful. And so the last message that I say is join us. Come join HCLA. Come join us. Come donate, and you'll see what an amazing place this is.
Yes, thank you all. I want to leave everyone with one comment, because we hear a lot. You know, this is actually a opposition tactic, is to demean your mission, to try to dissuade you, to divert us to something else, to tell us it's a pipe dream, right? It's impossible. Everyone on this call is a fighter. And so I want to quote, I never cared about fighting, but I loved Muhammad Ali, because that was a fantastic man. For people that don't know all the wonderful things that he did. And he had a fantastic sense of humor, and he was just smart. And what he said was that impossible is a big word thrown around by small men who refuse to see and to use their ability to change things. Impossible is not a fact. Impossible is an opinion. Impossible means nothing. So yay, we know it's not impossible. And to those that are saying that to us, it's just an opinion, and it means nothing to us, because we're fighters. Yeah. So thank you so much, everybody. Erica, Paul, did you have anything to say? Good night.
Good night. I think you guys beautifully summarized everything. Just want to make an observation. When each of you were talking about what CalCare would do for you, it's going to make me tear up. I mean, your faces were beaming. I saw a shift. Diana, I saw it in you. And it just reminded me of, like, that's where we need to be. Talking about what CalCare does rather than talking about the crap we're all dealing with. But there was joy, there was light, it was fun. So, as it was said, CalCare now. Let's fight for CalCare, and join us at hcla.org. Thanks all.
Good night, everybody. Thank you so much for joining us. Everybody,
thank you, everyone. Thank
everyone
you.
Unmute and say good night.
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 You.
Night.
Amazing.
See you in the street.